Okay, hi Cindy.
Hi, Robin.
Nice to see you. Welcome to our GPAC channel.
Great. Thanks for having me. Appreciate it.
Yeah. So we connected on Instagram and I saw one of your posts and it just stuck out to me because, we're both breast cancer survivors, but I also saw that you're an RN. So I kind of wanted to get your perspective. At GPAC, we are really trying to connect with more medical professionals and just kind of get the word out there and what we're seeing in the patient community, bring that to the medical community. So I would love to know your experience.
Okay, great.
Yeah.
Well, to start out, I was diagnosed with triple negative breast cancer, which I'm sure you know is the most aggressive form of breast cancer. Kind of a shocker, although breast cancer runs way deep in my family. I was also tested positive for the BRCA gene. So it was a slam dunk that I was going to have a double mastectomy. When you have triple negative, it's even if it's just in one breast and it's small and it's tiny, it doesn't matter. You really need to have a double mastectomy. So to make a very long story short, I had a double mastectomy, but that day of that surgery, I had a straight to implant procedure. That
Okay.
the minute they did the double mastectomy, so I had the breast surgeon there to do the double mastectomy, but at the same time I also had a plastic surgeon there to insert the implants. So I went straight to implants, and unfortunately, it wasn't too long after that surgery that I started just feeling real groggy. And actually, I knew I had a feeling, I shouldn't say I knew, I had a feeling it was the breast implants because I was getting symptoms before I started chemo.
Oh, okay. So how long after your chemo, or I'm sorry, how long after your surgery did you do chemo?
Not for another maybe 6 weeks, 6 to 8 weeks.
Okay.
Yeah. So within those 6 to 8 weeks, the brain fog set in, and doctors were putting things off. They were saying, you know what? It's probably still the general anesthesia. Well, as a nurse, no, It after 8 weeks, that general anesthesia definitely metabolized out of my system. So
Absolutely.
I
48
was
hours
I
top,
know.
right?
Exactly. I wasn't buying that. You're still feeling the remnants of the general anesthesia. So
Right.
I really, and I have to say, I did ignore it. I knew I had the symptoms, but I did ignore it, thinking, this too shall pass. It's all part of the surgery itself. It's a major operation, and so as each subsequent week and month and year went on, I kept feeling worse and worse. I got fevers, rashes, the joint pain, the inflammation. As a matter of fact, I have pictures to prove my face was out to here. And
Wow.
I wasn't on steroids, I wasn't on any medicines that would cause me to have this type of a reaction. And it was very frustrating because doctors did not know what was going on with me. And so their reaction was like this, and I'm sure you're very familiar. Oh, it's nothing. You know what? Maybe we should put you on an antidepressant.
Or
Yet,
or you're just getting old and you're just busy and stressed out.
yeah,
Yeah.
it's your age. Yeah, you have a very high stress and high pressure job. It's your job. It was everything, but let's take a look at your implants. Nobody. And I think as a medical professional, regular primary care physicians and even specialists, if they're not breast specialists, they don't really know to look for that. So that's why I'm grateful to you and your and GPAC, because I'll tell you, we need to educate. We have to educate these surgeons, these oncologists, the plastic surgeons, the general surgeons. Everybody needs to know, because I'll tell you, when they removed my implants, not only because they knew I was a nurse, they kept them out and showed them to me, but they let me take them home. Um, they were so disgusting, and mucus and pus, and I do have pictures for proof. They were it was just so mind blowing to me that this was living inside my chest cavity.
Right.
How could it not wreak havoc on the body?
And how long did you have yours in?
Let's see. So my surgery was 2015, and I had my explant on December 31st on New Year's Eve, 2018.
Oh, wow. Okay.
Yes, I had
Wow.
I had a scramble at the last minute. I had it up to here, and I found through one of my breast cancer support groups, I had found a plastic surgeon about 25 miles from my home that was able to squeeze me in at the last
Wow.
minute. Now,
Yeah. At the 11th hour
at the 11th,
to get on your insurance, because you probably already met your deductible that year and
yeah.
whatnot.
Oh, I did. Yeah, absolutely. Yes, yes. So I was really grateful to him for squeezing me in. And you know what, Robyn? Literally within 24 hours, it was like this aura. I felt such clarity. It was absolutely mind blowing. The next day, I thought, okay, I'm going to feel like crap because of the general anesthesia. But guess what? It was amazing the clarity that I felt. The brain fog just disappeared. My rashes, I had rashes all over my body. Every one of them went away.
Yeah, me too. I had them on my chest and on my legs, which was really
And that's
strange.
where mine were. Mine were on my legs.
I
Yeah.
wonder why the legs. I didn't understand that. Yeah, I didn't even know that that's what mine were from.
Hmm.
It's crazy how our stories are so similar. And I haven't even really communicated with you that much until today, but your story is like exactly the same as mine.
I know. Yeah.
I
When I
only
was
had
reading
mine in
your
for 4 months.
story, and
Yeah,
I thought this is my breast cancer explant twin.
yeah. And it's like, so, and I mean, I have a friend in Australia and it's her same story too. And she didn't have breast cancer. She did a preventative mastectomy for
Mhm.
BRCA.
Oh wow.
And, but same thing. And I find it really interesting. I wonder if this is becoming more, well known in the breast cancer community because I'm seeing that a lot of patients are experiencing earlier diagnoses because we're getting our mammograms and we're more proactive about our breast health.
Yeah.
But what's interesting is I'm running into more patients that didn't have chemo or radiation, only surgery,
Mm,
which I think is a blessing because then you're able to figure it out quicker.
yeah.
Because I literally had no other reason whatsoever in my life that I could be feeling as sick as I was and experiencing such debilitating health symptoms. I couldn't figure it out. I mean, I had gone back to my doctor, my surgeon numerous times, and she just gave me pills, muscle relaxers, pain pills, sleeping pills. I'm like, I don't want pills. I just want to feel
Same
great like
thing.
I felt when I
Yeah.
had breast cancer.
Yeah.
So
That's exactly what happened to me. I was just given, they actually put me on Ambien because I had insomnia. I never had insomnia
yeah.
prior to my
Okay.
implants, never had a sleep problem ever. So I was given Ambien, I was given anti-inflammatories. Oh, same thing with as you, Robyn. It was very, very frustrating. Yeah.
Yeah. So I think that I like what you said about, none of your doctors knew anything about this. We need to do better with getting this information out into the medical community. That's probably been one of my biggest frustrations because, I actually, when I testified at the FDA in 2019, I said it in my speech. I asked the FDA, please let all practitioners know that this can happen because I was lucky that I figured it out early. But I have friends, really good friends of mine that suffered for years. And, women should not have to be sick for a decade and spend tens and hundreds of thousands of dollars trying to figure out what's wrong with their health. So that's been the most frustrating part. And then, I have formally asked the FDA on numerous occasions, to issue a healthcare provider letter. So just recently in March, we wrote a letter from GPAC asking for, basically a formal statement on why the FDA has not issued a Dear Healthcare Provider letter, which they typically do, when there's new safety information on a drug
Right.
or medical
Yeah.
device. And, the response that we got was very paltry and disappointing because I felt like, their email said, well, we have put out information. They put out a video, what you should know about breast implants. They informed us that it got over 50,000 views on YouTube. They also had another update on systemic symptoms with breast implants that got 50,500 views. And then they have email subscribers that subscribe to get updates from the FDA about,
Yeah.
calls and health information. And they said that their communication went out to over 200,000 subscribers. So I found that very interesting. And I started doing some research on healthcare providers in the United States. And my research came up with there are right around 1 million licensed physicians that are licensed to practice medicine in the United States, and 3.8 million nurses who are licensed, providers in the United States. So 3.8 million and another million doctors is 4.8 million.
Mm-hmm.
And the FDA communications on this only reached 50,000 and 200,000 people.
Ridiculous.
Unacceptable.
What's the rationale for that? How do they even think or feel that this is acceptable? 50,000 out of almost 4 million?
Right.
I mean, that is ridiculous.
Right. So yeah, and that's when it really hit me that I think it's going to be up to us. It's going to be up to our grassroots movement and our boots on the ground to get into the medical communities and get this information out there. So I think that is going to be the wave of the future. I don't think we're going to get the help we need there. So, I'm kind of one of those women where if you want it done right, do it yourself. So if we have to do it ourselves, let's do it ourselves. Let's work together and get this information out there. And, I just did a actual CEU presentation last month about informed consent. And, I'm a member of a patient advocate association here in Arizona. And it was so great because the people on that call were like, well, I was debating if I should join this, for credits or not, but I am so glad I did. I had no idea about any of this. We also have a surgeon, I don't know, do you know Laura Bowden?
I know of her.
Yeah. So she's one of the original advocates against, breast implant illness, and she worked for Dr. Pryor, and they actually met and did a CME course with some medical students, which I thought was fabulous. And this is what we're going to need to do. We're going to need to gather together and just get these educational presentations out there. We're going to need to show up to the annual society meetings and conferences. I just attended the National Consortium of Breast Centers conference in March in Las Vegas. So tons of breast cancer centers all over the United States, came to this conference. It was multidisciplinary, so that was great. So I think we just need to be creative and find ways to reach the audience that needs to hear this.
Absolutely, absolutely. And because of all this, and because of you and your partner, I plan on getting very active in the Midwest in my area. I'm in a great big I'm in Chicago, a suburb of Chicago. So, and being a nurse for almost 40 years, I have a lot of medical professional connections here. Awesome. I also have worked for the major health insurance companies. So you can count on me to actively participate and get the ball rolling, because I would like to give back. I need to pay it forward. And I have a lot of experience with speaking to the public. And so starting today, I'm going to go gung ho on this. I really am. I'm going to help you guys out and start in my local community and expand outward. So you and I will chat after this interview.
Yeah, I was just going to say, when we shut it off, let's chat, because I have so many ideas already.
Oh yeah, I do too. Too. So whatever I can do to help you guys, but I just want, I don't want anybody else to have to suffer for what you and I went through. But I feel that patients need to know that there are other options.
Right.
When you have a mastectomy, it is okay to go flat. You don't have to have implants. the surgeons need to let the patients know, you know, Cindy, you don't have to have implants. We can just close you up and make it look as smooth as possible, but you don't need to put foreign objects in your body.
Right.
And that was it never even occurred to me 7 years ago. It just never occurred to me. I wish somebody at the time would have said, this is an option, breast implants are an option, but also no implants is an option as well. And I don't think the top breast, for any, not just top breast surgeons, but any breast surgeon, I don't think they are offering a flat closure. I just don't think, and I also don't even know if they're being trained to do that as well.
Right.
So there's a lot of surgeons that don't know how to do that.
And you know, that's a good point. I don't think they're trained and taught to present this option. So we recently had the NCCN guidelines changed to include flat closure as basically part of the breast cancer experience. So that apparently is a really difficult thing to do, change the NCCN guidelines. And Andrea Otanyo and I, she's in New Jersey, she's another flat advocate. We worked really hard on our proposal to NCCN and, you know, explained to them why this is important. And, you know, I think the tides are changing, but these are the things we need to do. I just had a call earlier this morning too, where we talked about Band-Aids and just fixing, you know, the Band-Aid,
right,
the symptoms and stuff. We need to get to the root cause. Why are breast cancer patients experiencing this? Because their surgeons aren't trained to do it a different way.
Exactly.
So if we can get that word out there, if we can change the guidelines so that when they pick up that brochure of the patient guidelines, so we not only got the clinical guidelines changed, we got the patient guidelines changed. So I think the more we normalize this, the better off everyone's going to be, because one of the biggest complaints I hear from, you know, the BII breast cancer ladies is, I was never told that this was an option. And, you know, in a plastic surgeon's defense, you know, they are plastic surgeons.
Exactly.
They do surgery on patients to make them look plastic in a certain way. And, you know, but when we're talking about cancer and we're talking about putting our health first and our safety first, you know what I just realized? I was just doing, right before we got on this call, research on an article that I'm writing. And I got out my breast reconstruction booklet that I was never given before my reconstruction surgery. I had to ask for this 5 months after my explant surgery. And I was looking in here and looked under the title of contraindications for getting Mentor Memory Gel breast implants. And it said, Mentor breast implants are contraindicated in the following circumstances because of the risk of undergoing breast reconstruction with implants outweighs the benefits. And one of the criteria is if you are a woman with existing cancer or precancer of the breast who has not received adequate treatment for those conditions. So if you're not done with your chemo, your radiation, you know, you should not be getting breast implants because the risks outweigh
the benefits. Unbelievable.
I would say 98% of surgeons are doing it the wrong way.
Right.
And why are they not following these guidelines? These guidelines are coming straight from the manufacturer. I can't tell you how many patients I know that were just like you and I, rushed into reconstruction right at the time of surgery. Yours was direct to implant. Mine was immediate reconstruction with tissue expanders. So I had those in for 3 months before getting implants. And I've had patients that have been radiated with expanders in, radiated with implants in. They've had expanders in for 12 to 15, 18, 24 months. That's a temporary device that's not meant to be left in the body for over 6 months.
Oh my gosh.
But surgeons are leaving them in patients for over a year. And I'll ask the patient, you know, why have you had your expanders in for so long? Well, we realized I need radiation treatment. So, you know, they decided to put it off and do treatment. They shouldn't even be doing treatment. You know, it's a contraindication. So there's so many things wrong. We need to just re-educate all of the surgeons. And
do you know, excuse me for interrupting, do you know when that was written, that booklet, that pamphlet? Was that
so this one is April 2016. And I'm pretty sure the current guidelines say the same thing, but I'll confirm that after we get off this call. But,
Mhm.
you know, I got mine in 2017, and it's just, nothing's changed, you know? So we have a lot of work to do, but I think it's great that we're finding each other on these
Yeah.
platforms and
Meant to
connecting with
be,
each
meant to
other
be.
and utilizing our network to get this
Uh-huh.
done, because it's going to be up to us. And
Yeah,
honestly, I'm up for the task. I can tell you are too.
I
So
am
let's
for
do this
sure.
and get it done.
Absolutely. Yes. Thank you so much for having me. This has been wonderful, and whatever I can do to help this cause, because I am so passionate about spreading the word and educating. I'm all about preventative and patient education. And at this point, physician and provider education. Actually, they need
Absolutely.
it more than the patients right now.
Exactly.
Yes.
Well, I agree with you, and welcome to the team. We're happy to team up with you and get this done.
Great. Happy to help, Robyn. And
Thank
good
you.
luck to you guys. And thank you for all you do.
Thank you.
Okay. Take care.